So I will introduce my friend Favila here. So
You can introduce me without paper, Elbow.
no, I'm going to read the whole thing. So Dr. Favila Escobio is a medical doctor with a specialization in family medicine and community medicine and an MSc in palliative care. He has worked in humanitarian crises, focusing on migration and displaced populations, the integration of palliative care in humanitarian settings, and the inclusion of older people in humanitarian responses. Dr. Favila Escobio worked as the humanitarian health advisor for HelpAge International and is currently working as a palliative care referent for MSF Operational Center Brussels, supporting MSF teams with palliative and end-of-life care. Today, Dr. Favila Escobio will discuss examples of the healthcare rights and needs of older people from different humanitarian crises.
Thank you, Elbow. Thank you. I'm gonna read what I will say because I'm very bad on public speeches and I forget everything and I want to say a lot of things. So I don't want to forget anything. The first thing I apologize is because I have a strong Spanish accent and I tend to speak very fast. So if you don't understand anything, just stop me or somebody will tell me to finish. So when I began preparing this presentation, I wasn't really sure where to start or what to say. I was really excited. And I have to congratulate Elbor for the amazing work that she's doing for long. And I feel that I'm really following on her path. So it's really a pleasure, Elbor, to be here, really, because you are doing amazing. And I want to thank also HelpAge. And a lot of the conversation now is turning around MSF. I'm part of MSF, but I was also part of HelpAge. Today there was a mention that older people are like books, that keeps the knowledge. And I would say if there's an organization nowadays that really keeps the book of knowledge of working with older people in humanitarian settings is HelpAge International. So thanks for that, and I hope that this will continue ahead. So, well, the thing is that there's many people working now on this domain, or a good bunch of good people working on this domain, but still, and the momentum is growing. But we have to be clear and repeat something that is a real truth. That is that older people are missing from humanitarian responses, period. We can discuss about prioritization, not prioritization, but the thing is that we are not even discussing that. We haven't arrived to the point of talking about older people. So I think this is a very good moment to at least later on define what we are going to do. But that's the reality. This absence is quiet, is systemic, and is normalized. And this has enormous consequences. Today, the speech is about what we are saying. We are talking about older people like if they are a special interest group. They are not. They are part of society. We are all acknowledging our families and our communities. So we cannot talk about them just like a special separated group. Definitely neglecting older people, and I will put examples from humanitarian and non-humanitarian settings, is definitely missing something that has been discussed as the intergenerational systems that holds families and communities together. Maybe this is very philosophical. I'm a family doctor, so it's not my area of expertise, but the society we are living is changing. It has changed very fast. So I live 3,000 kilometers away from my family because I live in Hungary, my family is in Spain. And so these connections are missing because it's the way we are living nowadays. Industrialized, capitalization, whatever you want to call it. But there's a shift on the reality. So not talking about other people is not talking about this intergenerational system. And it's not talking about those who cares older people, which are people who are unpaid, unsupported, and invisible. And I will stop later on that part, that is the informal caretakers and how they play a big role on working with older people. This works with this point.
It worked. Take a few times. No.
I just want to stop. This has nothing to do with the topic of today, but as a professional health worker, a humanitarian, I think that it's important to do, at least I want to dedicate 1 second to the situation in Gaza. Probably politically it's changing, but I wanted to really acknowledge in this topic because it's a public event. So I'm very happy to position myself on this regard and also in the name of MSF. We don't know about older people in Gaza. I've been following with HelpAge for 2 years through local organizations, which are doing an amazing job in there. And the data that we have, especially about older adults, mortality and morbidity patterns, what's happening with them is non-existent. This is not focusing also only on older adults, but I wanted to bring to the attention of today. Next slide. Sorry. And this is the little boy there. It's my grandfather, Cesario, and these are his brother and sister. And I put this and I become a bit emotional because it's what you are saying. I mean, this is about our families. And when I talk about other people, I'm thinking on them and how important they were for me and how much they mean. So in a way, it's a way of also expressing gratitude and respect. They endure a civil war, they endure dictatorship, they endure other many things that happens in normal life. But for me, this is the kind of respect I would like to pose to my family. I come from Spain, from a Mediterranean country. Today is the 5th time I mention olive oil in conversations with someone. And like in many Mediterranean societies, older adults has played an important and tremendous role. They are sources of experiences, and they have been and they are active participants in family life, many times caregiving for grandchildren. And they have been always considered respected community members. And aging has been always a privilege and something considered with dignity. But these values, as I say, are under pressure. Urbanization, economical change, shifting family dynamics that I mentioned are reshaping how, and especially how well, we care for older adults. I hear many phrases around me, clinical practice or with friends, how difficult, okay, I don't arrive to work, oh my God, my father or my father is getting old, I don't know how to deal with this situation. And for me, it makes me think how this is completely out of probably how our societies were growing, and we were growing all together. And this was something that is really shifting the way we discuss. In primary healthcare, in my consultations in non-humanitarian settings, I see older patients juggling multiple chronic conditions, complex medications regimes, including unnecessary polypharmacy many times, lack of access to proper social services, families, caretakers not understanding what's going on, what long-term care is, what home-based care is, what palliative care means. And this is underlying many times also psychological burden, like isolation, grief, and caregivers fatigue, which usually they are not recognized in routine visits. And I'm putting the example of a developed country because most of you are here also from the Netherlands, and let's translate it into humanitarian settings. So saying this, I come from this system, from the Spanish National Health System, which has proven a very good universal health coverage, strong primary healthcare system, and a good multimorbidity disease management. Yuka was mentioning the base of the primary healthcare. Despite of that, there are a lot of challenges on geriatric training, primary and emergency settings, underdeveloped long-term home-based and palliative care needs, an aging paradigm, which we are still focusing on managing diseases and not managing people. We are not treating people, we are treating diseases. So where I come from, nearly half of older women report mobility issues, and 1 on 3 adults in Spain over 75 takes 6 or more medications daily. And as I say, long-term care relies usually on unpaid and informal caregivers, mainly migrants, who has nowadays minimal formal support. So if this is the reality of Spain, let's say a well-developed country, what is happening in humanitarian context? And this slide. So again, a reference to Gaza, but yes, so an example. So today has been largely discussed. I mean, older adults are not counted, are not consulted, are not prioritized, deprioritized for sure. Emergency settings have often focused on maternal and child health. Fair enough. These are populations with immediate life-threatening vulnerabilities. And I think there's a work that we haven't changed because there's decades of funding, global commitments, and especially measurable indicators. We can measure everything nowadays about child and maternal health. And this is not happening related to older adults. And many times I feel hopeless having these conversations with meaningful and outstanding colleagues where we discuss about older adults data. This is not existent. Sometimes I hear mentions that we are not seeing this in our consultations. I mean, this is not the type of patient that will arrive to our facilities. And it's like, yeah, no way, but maybe we are doing something wrong. Maybe they are not coming to the facilities because maybe we should be looking for them. Maybe they are somewhere else. I don't know. It's the top of the iceberg, what we are seeing. And even worse, many times I've been listening this word that I hate, that is called, this is not an operational priority. So I think one of the points of today is this, how these operational priorities, these decision-making processes can change. Maybe most recently, Ukraine has shaped a bit the discussion, and it's a great example But it's also a great example of how we humanitarian actors are not prepared to respond. After 2 years or more of 2 years of war, we are still not knowing how to respond to older adults. We are still managing chronic diseases. We are talking about diseases. We are not talking about people. We are not integrating social and medical care. But older adults, as it's mentioned, they don't live only in Ukraine, but in all humanitarian settings, forgotten crises, Sudan, Palestine, Myanmar, DRC, Syria, Yemen, Venezuela, and so on. Aging exists, older adults exist, but they are invisible. They are not planned, they are not measured, they are not talked about. So there's this systemic neglect. I always try to come to the same example. I repeat it many times. It's in 2014, ISIS took over parts of Syria and Iraq, as you many know, and what is called nowadays the Yazidi genocide. At that time, we didn't know it was a genocide. I just remember that camps were overwhelmed with families, with kids, with women, with young adults, but there was a group that was not existing there. It was older adults. Why? Some refused to flee, unwilling to abandon their home. Others couldn't survive the journey, or for sure they were not in the spotlight of what it was the rescue and their particular needs. Years later, because of course genocide is not named or discovered at the moment, but years later, massive mass graves reveal how systematically older men and women has been targeted and killed. And this is part of the Human Rights Council session, in a literal example of execution of older women. So their absence in this response wasn't an abnormality. I think it was rather a warming, but unfortunately this warming is still nowadays around the world very present, that how older adults are invisible. Please, next one. So many people today is talking much concrete and better things like me. I say I'm putting this from the clinical lens. So what I see for on the ground is clear. We are failing to adapt to the complex needs, health needs, I'm talking of healthcare needs of other population. Data collection is missing, and clinical services, they lack the capacity and the knowledge to manage a person-centered approach. But let's be positive. In many contexts, and I saw some people also connecting who are doing very meaningful things, there are local and community actors, frontline health workers, who are starting to acknowledge the needs of older adults. And they are starting to integrate into their practice. They started to be trained in management of geriatric syndromes, management of polypharmacy. Tools like ICOP that Dr. Yuka presented today are discussed to be adapted, even in low resources settings. And so this is very positive. And I think some community-based programs are finding a way to bridge this clinical and social care that we are missing, and how to work through informal caregiving networks. The babushkas of Ukraine, the work that HelpAge is doing in Ukraine through informal caretakers is a very good example. These examples show how it's possible, but unfortunately they remain the exception, it's not the norm. So I think that to change this, we need to ask ourselves how those services can be actually built to care for older adults. It's not only about the physical access, how people can access, but really how we can bring this group of population to our activities. So I think it's shifting from a reactive to a proactive change, and recognizing, also it was mentioned by Yuka before, how primary care must be the backbone for older adults in crisis settings. And something that we tend to forget, even in MSF, is talked a lot, is about how community engagement is core and the voice of older adults may lead these responses. So there's this dominant model, episodic and disease focus, again, that I think is inadequate for the management of the complex needs of older adults, multimorbidity, frailty, cognitive decline, and unmet needs of older women, sexual and reproductive health aspects, menopause, cancer, breast cancer, cervical cancer. I mean, this completely does not exist. And then two terms, the long-term care and the palliative care needs. As I say, clinical care doesn't happens in a vacuum. I was talking with someone before who's working here in the Netherlands. Briefly, it was discussed the issue that medical care has to go hand by hand with social care. And Brice Mother, you mentioned something similar about social aspects. So many times these informal caretakers are the ones who are really carrying the weight of caregiving, because clinical care is not only the medical, as I say, it's also emotional, it's social, and it's logistical. In mostly every humanitarian and non-humanitarian settings, informal caregivers, which are mostly women, as I say, and in developed countries, mostly migrants, are the ones who administrate medications, who helps with daily activities, who manage transport, and they are the ones who holds everything together. So these networks are overstretched, they are undervalued, and without investing in them, we are building fragile and unsustainable responses. So now, just briefly, I want to focus on an area in which I think we should do much more to support older adults in emergency settings and not, which is the integration of long-term care and palliative care. So as I mentioned before in one of the comments that we are having in 2025 this year, there was an update to the Lancet Commission on Palliative Care, published in the Lancet Global Health. It makes the case with brutal clarity. Serious health-related suffering, for those of you who are not familiar with this concept, is a proxy that measures pain, distress, and severe health condition, is rising extremely fast, especially among older adults. So it's expected by 2060, around 50 million people dying each year with untreated or poorly managed suffering and pain. And this is increasing, especially in the age group of 70 and older, and especially in people living with dementia. So yeah, still palliative care remains underfunded, misunderstood, or completely absent in humanitarian context. The dominant model that I mentioned of saving life is not designed to respond and to manage the reality of people from Spain, my home country, to Syria. Pain, frailty, chronic disease, or cognitive decline. And we see the consequences every day. Pain goes untreated, mental distress is ignored, and older people and their families are left to navigate serious illness completely alone and without support. So the studies and the evidence shows that integrating palliative care, not just end-of-life care, but through the continuum of care, improves better outcomes, is cost-effective, improves quality of life, reduces hospitalizations, and provide vital support to families, even in very constrained systems. But as I say, implementation is still very rare and very difficult. So this is not just about dying, it's about how we live and living well, living in crisis, restoring the dignity that I mentioned before, maintaining the function, and making sure that we are really working on this moral imperative of humanitarian workers of not leaving anyone behind, simply because they are too old, or I had always this phrase also of because there's nothing else to offer. So just like homework or what we can take from home for all this blah, blah, blah that I'm doing. So definitely we have to make older people visible and we have to talk about them. This is a great space, but how we can keep this in our conversations, in global health discussions, with donors, frameworks, humanitarians, with our families, with our parents, with our friends. We have to. And this is not about adding a vertical program, something silly. It's about redesigning the system and to reflect the realities of aging. I mean, this we can believe it or not, we can deny it or not, but we have to be prepared because the reality is on our face. Populations are aging. And recognize that this is a human right. This is not negotiable. On the operational aspect, definitely we have to assess it. We have to see the real healthcare needs of older adults. It's not only about measuring the prevalence of NCDs or disability, which is not bad as a starting point. It's not only about age, sex, disaggregated data, which is not existing and the same, it's a good starting point, but it's really responding to the real needs of older adults. To switch from this disease-centered approach that I think we are very good at towards this person-centered approach. It looks very good on slogans, but we are very bad on implementation. And to have practical tools and frameworks for inclusive healthcare. For that, stay tuned for the upcoming Lancet series on older adults. We have to train health and social care workers working in humanitarian and non-humanitarian settings in older adult health. I don't want to call it geriatric care, I don't want to call it palliative care, but I want to call it the continuum of care. And the last and the most important and the most difficult is the community. I think we really need to support and resource these informal caregivers. We are really carrying the weight, most of our societies, humanitarian and not humanitarian. Strengthen these community-based models and how we can link to clinical and social care. Forget about this distinction of clinical, social, protection. And definitely what I say, include all the adults in our discussions and decisions, because as we all want, and I think we all agree on that, we want to be the captains of our own lives. So I think all the adults, and I'm hope to arrive to be another adult, even if I am already, I want to take the own decisions of my own life. I don't want anyone else taking that from me. Well, if I'm where I'm capable, of course. So thank you very much.
There any questions for Favila?
I came just from the station and there were people that were like handing out these flyers about like protesting for more right to choose about your end of life. So I don't know if I'm sure this euthanasia. Yeah. And yeah, I was wondering how you think about that. What are your
Oh, that's a very deep question. I mean, if you just to frame it, what's my thought on euthanasia, or please reframe it because I'm probably I didn't get it very well. Okay, I will probably not answer the question, but something brief, and I think we have a very good expert on the domain. Unfortunately, something I face on the day-by-day working is that many people confuse palliative care and end-of-life care with euthanasia, especially in very resource-limiting settings. And this is posing nowadays a lot of ethical dilemmas to healthcare workers. That's what I can tell you. Many people is really thinking, from health staff to community members to patients. They think that when you are telling that we are entering into palliative care and explaining them that is to improve quality of life, etc., they are really thinking that we are trying to reduce their life expectancy or that they want to practice some type of euthanasia. So I'm not really answering the question, but yes, it's an ethical question that arises very, very often.
And do you want to comment on this discussion, or do you want me to ask my own question? Whatever. Okay. It's really impressive how this issue gets up all the time, right? About end of life here. Must be Dutch. Okay, so I guess the standard answer to your point is it would be a poor society if rather than providing care, we provide a quick way out through euthanasia, right? So normally we would say, okay, so if as a society you want to provide, let's say, interventions such as euthanasia, suicide, medical aid, and dying, whatever you want to call it, then please get your palliative care up to speed before you do that. That's exactly what happened in the Netherlands. However, once again, I went against the stream because I argued, actually, I can give you the reference, that it's also very strange to respond to someone in a humanitarian crisis, whatever, let's say, dire need situation, to say, hang on. In 10 years' time, you'll be our guest, right? Because first we have to build palliative care structures. So although as a public health response, I agree with what I just said, build up palliative care first. Yeah, the reality is also that this individual is now invariably suffering. And you cannot simply say, come back in 10 years or 20 or whatever. So in spite of the fact that, maybe I should be clearer, in ethics, you really have to discern between an individual response and a, let's say, public health response or a public level response. And as public level response, I think, wait, but for the individual, that is too harsh. So maybe in some cases, there might be room for an individual acceptance of the request. Whereas in general, as a let's say public response, you should first get your palliative care, right? And that was actually my question, because I once heard, but I'm not sure whether that's still the case, that the biggest question in palliative care in low resource settings is access to morphine. And now I don't mean access to morphine by patients, but by healthcare professionals, because laws in many countries actually prohibit such opioids, because that's what they are, opioids to enter the country. So palliative care is really also hindered by, let's say, all kind of drugs, all kind of laws that actually are created to, let's say, resist the import of drugs. And now I mean addictive drugs. And that is actually, that's a thing that we might be able to change, right? And then it's not so much money or accessibility on the individual, but it's actually rules that are man-made or women-made, but anyways, that are made by governments that prohibits the entry of palliative drugs. Yeah, is that still the case?
Yeah.
Yeah.
Yeah. Yeah, thank you. Yeah, I can just make a small comment on that regard. I think one of the biggest structural barriers for the implementation of proper palliative care, by definition, what palliative care is the access to opioids for what? I mean, and as humanitarian organizations, many times there's a huge barrier to access. Not talking even about the ethical aspects, misunderstanding access of staff is on this level, on the Ministry of Health or central levels. So many times, unfortunately, what I see, what happens is that some of the palliative care that is provided is a bit split into more the social care or the spiritual care or the mental health care, while let's say the more medicalized approach of pain management control is not accessible. But it's not accessible because these barriers exist worldwide, and there's all this narcotic discussion that I think in that case even MSF is not very much advanced on that regard. It's very much country by country, project by project, situation by situation. But definitely is one, I think, the biggest institutional barrier.
So basically you're saying, yes, indeed, unfortunately, that is still the case. Then what can we do about it? Because, I mean, you can create laws with exceptions, right? You could say for medical purposes, for medical purposes, it will be okay to import opioids. And of course, there is no system that cannot be gamed or that cannot be misused. So I acknowledge that, but basically, governments are creating barriers for their own population to be treated when they are suffering.
Yeah.
It's a different type of barrier.
Yeah. Yeah, I think that will require exactly a full discussion on the topic. I know now, and probably some of my MSF colleagues know even better than me, there was the previous Access campaign that is not called Access campaign anymore. It's something about different medications, how to access. I think the discussion about opioids was never put on the table, maybe, sorry if it was. So this is just to say there's something that I think even for an organization such as MSF, this should be discussed. But the summary is that absolutely that's the main barrier as of today. Yeah.